Hello and welcome to this webinar, which is brought to you today by ESTES, the European Society for Trauma and Emergency Surgery. Our panel today will be addressing the topic of small bowel obstruction and exploring the question, do we really know when and how to manage it? To do so, they'll be focusing on diagnostic imaging, decision-making and surgical management, and the specific problems of small bowel obstruction in bariatric patients. There will also be an interactive case presentation with a number of polls at key decision points. There are seldom any right or wrong answers, and the responses are all completely anonymous, so please take part. We really do want to know what you think. We'd also encourage you to use the Q&A button to ask questions of the panelists as we go along. So I'm going to hand over now to Ioannis Gerogiannis to introduce the panelists. Ioannis.
Good evening, everybody. I'm Ioannis Gerogiannis. I'm a consultant general emergency surgeon. I have a special interest in laparoscopic upper GI, bariatric and abdominal wall reconstruction surgery, and I'm based at Kingston Hospital, London. We have a lot of excellent speakers today, and I don't want to lose time with introductions. I will just start straight away with Nirav Patel, who will talk about diagnostic imaging and the use of gastrografin for small
bowel obstruction.
London. He has some interest in abdominal and trauma imaging, body MRI, and radiology training. Nirav, you want to start with us?
Sorry, thank you. Thank you, Ioannis. Sorry, just sharing my screen here. Good evening, everyone. So my name is Nirav Patel. I'm a consultant radiologist, and I'm going to talk to you today about the diagnostic imaging and the use of gastrografin for small bowel obstruction. So I'll briefly go over the role of imaging, and then I'll talk about some of the general CT features that we see, but in particular, some of the high-risk features that I'd be looking for as a radiologist to suggest potentially operative management. We'll have a look at the role of oral contrast in imaging, and then briefly at the end, I will touch on recurrent small bowel obstruction. So I guess what is the role of imaging in small bowel obstruction? Well, it helps with the diagnosis, of course, but really when we're doing it, we're trying to stratify the type of small bowel obstruction. Is it present? Where is it located? Is it a proximal or distal obstruction? And what do we think the cause is? And in effect, we're also looking for complications as a result of small bowel obstruction. But ultimately, it's there as a tool to help the surgeon guide management decisions, whether we're opting for conservative treatment or operative management. There are lots of different modalities available for imaging small bowel obstruction, but really the keystone of imaging is performing a CT scan with intravenous contrast.
Nirav, I know you've got some wonderful slides. Do you want to share them with us?
Oh, sorry, excuse me, sorry. Is that coming through now?
It is now, yeah.
Sorry, apologies. Okay. So abdominal radiographs, are they useful? Well, potentially they could help triage patients when you first see them. But in reality, if you have an abnormal X-ray like this, you're often going to end up wanting a CT scan. And if you have a normal abdo X-ray, but you're clinically concerned, you're going to end up with a CT scan. So this is almost an old test, but we still continue to do it. And in reality, when we do them, they rarely change the outcome. So this is a large study that looked at 1,000 X-rays, and it only changed the clinical diagnosis that was suspected in about 10%. However, particularly for bowel obstruction, the sensitivity does increase in terms of diagnostic sensitivity when using radiography compared to clinical assessment. When we do a CT scan, there are some general features that we all know. We're looking for dilated small bowel loops and then essentially collapsed distal small bowel loops. So this is a good example here, nice fluid filled loops of small bowel, and you can see an empty terminal ileum here. When we see that caliber change is greater than 50%, we may suspect this is a complete or a high grade obstruction, i.e. potentially this patient may need an operation. Sometimes it's a little bit more difficult to identify the sites of obstruction, and on imaging there are some features that you can look for to help assist localizing the site of obstruction. One such one, which is familiar to many, is a small bowel feces sign. So this is where you have stasis of bowel contents. So you end up with absorption of some of the luminal fluid, and as a result, you get this semi-solid material, almost like feces. This usually occurs at the site of where you have stasis. So if you have an obstruction like this, you can see this angulated loop of bowel. You might have distension like this, and this can help point to the area of obstruction. It's worth noting, however, I see this often on normal patients, so it can only be used in the context of when you think there is obstruction clinically. And if you don't see it, it doesn't mean there isn't a bowel obstruction. This is an example of a pseudo feces, small bowel feces sign. So this was a 14-year-old patient, and you can see this area here in the right iliac fossa, and there was an angulated loop of bowel here, and this was described as adhesional bowel obstruction or suspected adhesional bowel obstruction. Now, what was key here is this patient was 14 years old, but also they never had abdominal surgery, and the patient had learning difficulties. And you can see on this CT scan, there are multiple loops of dilated small bowel. So they took this patient to theatre, no evidence of adhesions, but they did an enterotomy, and they identified that this was a latex glove. So the patient had been ingesting latex gloves. Good practice was that they came back to the radiologist to say no adhesions, but fortunately the radiologist reviewed the stomach and found 2 more latex gloves in the patient's stomach, which was endoscopically retrieved. So you can sometimes see this, and it's not a true small bowel feces sign. Another localizing feature that we sometimes see is called the beak sign. This is quite an obvious high-grade distended small bowel, and narrowing here helps you locate where the site of obstruction is. But you might see this in the context of peristalsing bowel as well. So you have to use it when you think clinically there is a bowel obstruction. And a similar associated sign, particularly in the context of adhesional small bowel obstruction, is something called a fat notch sign. So you can see this nice loop down here, distended proximal loop, and you can see an angulation there. And what happens is if you have an adhesion, you get a bit of mesenteric fat that notches around that adhesion and often shows up like this. You can see in a similar patient here, where you've got dilated proximal loop, this little notch here, and then empty distal loop here. I guess one of the key features as surgeons you'll want to know about is when do I need to operate? And there are features that we can look at on CT which help predict those patients that need surgery. And one of the things that I'm looking for is features of ischemia. Now, some of the features we may get are decreased bowel wall enhancement and mural edema. This is an example of a patient who has a closed loop bowel obstruction. So you can see 2 narrow areas here, and there was a band adhesion here. But this closed loop here demonstrates slightly reduced enhancement compared to these loops down in the left iliac fossa. And you can also see mural edema there. So these are features that suggest ischemia in that segment. Paradoxically, we may have the opposite here. So you get slightly increased enhancement of the bowel wall. This patient has an obstructing gallstone here in this loop of ileum, which is causing bowel obstruction. You can see some localized pressure effects on that bowel wall with some pneumatosis there. So there's some gas in the wall there. But you can see the adjacent bowel wall, which is really edematous, but you've got nice brisk enhancement of that wall in that region. Additionally, this nicely demonstrates the patient's mesenteric fold there, which is showing some mesenteric congestion and edema. Another feature which suggests potential surgery is seeing features of congestion. So you've seen it in that previous patient, but also you might just see mesenteric venous congestion, which can have an effect on the bowel wall. And as a result, you get edema and thickening like this. You might have generalized fluid, but also localized to the mesentery that is affected as well. And then if you have perforation, like in this case, a localized perforation or more disseminated free gas, obviously that necessitates surgery. And this is another example of a patient with gallstone ileus causing an obstruction here. You can see the proximal loops are dilated. You've got some mural thickening, some reduced enhancement here, mesenteric congestion in that loop there, and then localized perforation into that wall, into the mesentery there. And finally, another feature that might suggest needing surgery is something of closed loop obstruction. Here you have a patient with 2 transition points adjacent to each other. You have an adhesion across here, but you can see in this region here, you can localize congestion to that side, right side of the abdomen, And if you compare it to the contralateral side, these loops are slightly reduced enhancement. And this is something that we would need to suggest that the patient may need an operation. Another feature that you might see is a whirlpool sign. So this is just an example of a patient with a cecal volvulus. So you can see this patient has a distended cecum here. And if you concentrate in the right iliac fossa, you'll see that the vessels and the bowel loops there are swirling around each other there. So you can just see that appearance here, just this twisted motion, and the vessels do the same. Now, this will potentially suggest a volvulus or internal herniation. It must be interpreted in the correct clinical setting, because I often see normal CT scans, patients presenting for other reasons, and the mesentery does these funny things on imaging. So it has to be interpreted in the right context, whether that's a post-operative patient, for example, bariatric surgery patients, or just in the context of suspected volvulus or internal hernias. The best predictors of ischemia on CT are some of these that we've described: so closed loop mechanism, decreased bowel wall enhancement, diffuse haziness. But another feature we haven't discussed yet is increased unenhanced bowel wall attenuation. So far, I've been demonstrating cases where patients have had intravenous contrast, but no oral contrast at all. The reason why is we're looking for enhancement of the bowel wall and making that judgment about the integrity of the bowel wall. And this is an example when you give contrast, this is how the bowel wall may appear. So you can see some dilated loops, they're distended here, but we can't really make judgment of these loops really, because they appear to be enhancing. But these loops are not truly enhancing, because on the unenhanced CT scan, these loops with the bowel wall demonstrate high density. So you can see the high density here, compare it to these thin-walled normal density loops. And what's happened here is the patient has got localized ischemia. As a result, they've got microhemorrhage in the wall, and that's showing up as a higher density on a non-enhanced CT scan. I have to say, however, we wouldn't routinely do this as part of our imaging, particularly with a high volume of patients that come through our emergency department. But it's something to bear in mind if you are strongly suspecting bowel ischemia, to have a non-enhanced study as well. So moving on, why don't we give oral contrast routinely for CT? Well, ultimately, we're looking at the bowel wall and making an assessment of its integrity. And you can see nice images like this when you just give intravenous contrast. If we flood the lumen with high density contrast, the bowel wall just cannot be interpreted in a satisfactory manner. So the first thing is, we're looking at the bowel wall. Does this patient need to go on to have surgery? The other problem is you've got a patient who is obstructed, they're vomiting, because they're obstructed, there's going to be a delay in transit of the contrast through to the points of obstruction. So really, there's no point delaying that. But there are instances where it can be helpful, particularly if you're looking at patients who may have multifocal obstruction or potentially a partial obstruction, and you want to see if the contrast progresses through. But that should be done in the context of once the patient's admitted and discussing with your local radiologist to see what the best way is to make that assessment. The mechanism of action of gastrografin or other sort of related water-soluble contrast agents, such as urografin, is the increased luminal pressure that you will get as a result of taking this hyperosmolar agent. It will reduce the edema in the bowel wall by pulling in that edema into the lumen. It creates a nice pressure gradient across the obstruction, which may allow it to be relieved. And in addition, it stimulates peristalsis, and some of the inactive ingredients allow it to lubricate the point of obstruction. That's a proposed mechanism of action. This is a sort of standard gastrografin challenge protocol, similar but with some variations across centers in the world. But ultimately, you need a patient that's adequately prepped, no longer vomiting, with an NG tube in. You give the gastrografin, you wait 6 to 8 hours, or 4 to 8 hours, depending on your center, take an X-ray. It should reach the colon. If not, repeat the study at 24 hours. It should reach the colon. If it has not, then you need to consider surgery. Now, the patient needs to be selected correctly to go through this process before you decide to do a gastrografin challenge. This is an example of a successful gastrografin challenge. You can see a proximal bowel obstruction here, just so nice distended stomach, distended loops of bowel, and this was down to an adhesional small bowel obstruction. This patient had gastrografin. You can see at 6 hours, it's all the way through into the colon, down to the rectum there. So successful gastrografin challenge. This is a patient who has an unsuccessful challenge, 86-year-old male with abdominal pain and distension with a slightly raised lactate. You can see distended stomach, distended loops of bowel. There are features before that suggested that this patient may have ischemia. So you can see some mural edema of those bowel loops there. And I'll just skip to the next slide. There was a suspected closed loop mechanism on that CT. So you can see some localized loops on the right side with two transition points adjacent to each other. And that was raised as a potential closed loop. So before even trying with gastrografin, there were features that could predict ischemia on this CT scan. So the patient may need an operation, but I think there were patient factors in this case, which suggested let's try conservatively. Gastrografin challenge at 4 hours, it's still in the small bowel, nothing in the colon. At 18 hours, still in the small bowel, nothing in the colon. As a result, the patient progressed to surgery, which was appropriate. They had an adhesiolysis due to closed loop bowel obstruction, but fortunately no bowel resection was necessary. What's the evidence behind this? There are lots of studies going back over the last 2-3 decades looking at this. And generally there is a favorability towards persisting with gastrografin. At least it reduced the need for operative management. And this is the largest meta-analysis from 2016, which shows that it's favorable to give a gastrografin challenge, provided that you've selected the correct patients. However, there was a study by Scott et al., which published after this meta-analysis, which is the largest study looking at the two groups, and showed no difference in outcomes between the two groups. So it's still contentious, and there will be centers that will prefer to do it, and there will be those that won't. But there is some evidence that points towards it can be used effectively to reduce the need for operation in adhesional small bowel obstruction. I mean, one of the key things, however, is in those patients that it does work, it reduces the length of hospital stay in non-operative patients and overall stay, and it reduces the time to resolution. And in a world where we're trying to get patients in and out of hospital quickly, it can be a very useful tool for management. One of the key things is there's no difference in complications or mortality if you do not give gastrografin. And finally, just one of the points I wanted to make about recurrent small bowel obstruction. So often we get these patients who would come back with recurrent episodes of bowel obstruction. We put it down to adhesions every time because they've got a strong abdominal surgery history, and then they relieve and they go home. But this is just an example where we need to be a little bit more astute and listen to the clinical history, but also just pay attention as radiologists as well. This patient had bowel obstruction in 2018, presented again 2020, and again November 2020. Similar presentation, similar point of obstruction. That November 2020 scan demonstrated some liver lesions, one of which was biopsied, and this came back as a neuroendocrine tumor, a metastatic neuroendocrine tumor, which you can see on this PET scan here. Now, one of the key things is there was lymph nodes there at the time, and potentially we could have identified it sooner. I have similar cases over the last few years for primary peritoneal cancer, NSAID-related enteropathy, and potentially you could have low-grade Crohn's disease as presentations, which sometimes get written off as adhesional small bowel obstruction. But if you see presentations like this, go back to the beginning and think, why is this patient re-presenting several times? So thank you very much for listening to my talk.
Nirav, thank you very much for your talk. It was really excellent. I've enjoyed it a lot. I would like to ask you. Of course, we had a question from the audience, and I think you answered it very quickly during your presentation. Will the oral contrast efficient in obstruction, or should we avoid this? I think you were clear in your presentation. What I want to ask you specifically is that it is difficult in your role as a radiologist when a surgeon is asking for a CT scan and you identify an obstruction, then I assume you monitor a little bit the behavior of the surgeon. Maybe they will ask you straight away for gastrografin, or they will ask for gastrografin after a couple of days. Is there any, when is the right time to ask for gastrografin?
I think, well, one thing often in our center, colleagues will come down and discuss with the gastrointestinal radiologist, particularly if they've got some concerns. And I think that one of the key things is excluding other causes like hernia or malignancy or whatever it may be as alternative causes. And now, if you truly think this is adhesional small bowel obstruction, have a good look at the bowel and assess the integrity of the bowel. If there are no features that could predict ischemia, I think that is the right time to start within the few hours. Once they've settled, you've got the nasogastric tube in, the vomiting is settling, then that's a good time to start giving gastrografin.
I was asking that because I think Dimitrios in his presentation will say about the challenges in management of small bowel obstruction. But as surgeons, sometimes we are either very aggressive or very conservative. We have some surgeons that they ask for gastrografin from the first presentation, like a few hours after, or we have surgeons that are waiting for decompression with NG or patient to become a little bit better and then give gastrografin. As a radiologist, when they ask you for gastrografin and you see that the CT scan and the clinical findings that they write you in the report, which are equally important, we need to mention that. Have you been in a situation that you will not deny, like suggest for no gastrografin?
Fortunately, I've not been in that situation. I think particularly at our center, and Dimitrios works with me at our center, I think we're good at identifying those that clearly it's not indicated. But I think there are those patients now, as you say, there are some surgeons who would give it on day one, and some will realize that the patient's just not progressing in the right way at day 2, 3, and then will consider giving it. But I've not been in a situation where I've had to say, actually, I don't think it's the right thing. We should wait.
Thank you. Do we have any questions from the rest of the panel? I cannot see anything in the chat, the question and answer. So if we are okay, of course, we can gather the question for later on and we can discuss in the end. We will move to, thank you very much, Nirav.
Thank you.
We definitely want your input later on. Will be some also questions. So we will move to the next speaker, who is Dimitrios Tsironis. Is a consultant surgeon in emergency and upper GI surgery in St. George's University Hospital. I know Dimitrios from actually when we were in the Greek army and together long time ago. He's a very good friend of mine, and he's an excellent surgeon. And I'm looking forward to hear about his opinion and his choices about how to manage a patient with a small bowel obstruction. Dimitrios.
Good evening, everybody. Thank you very much, Yanni, for this invitation, everybody on ESTES. I think after this very good presentation from Nirav, I don't know if I'm going to answer all the questions, but maybe raise some more questions. I'm going to start sharing the screen and then we can discuss it. Okay. So, as Yanni said, I'm working at St. George's Hospital in London. I'm one of the consultant surgeons here, and with Nirav, we work quite closely together on a almost daily basis to discuss cases. When we were discussing with Ioannis about the presentation regarding small bowel obstruction, actually what was coming to my mind had to do with how much the evolution and the new diagnostic tools we have today have changed the management of the small bowel obstruction, and if it is one of the conditions that we have progressed a lot, or are we using the traditional techniques? And also, when is the right time to operate? Because I'm sure most of you, at least with my experience in the hospitals I've worked in Greece and in UK, every surgeon has a different choice on the time to operate. So we need to see if we have appropriate guidelines for that. And when is there, if there's any space nowadays for conservative approach, because the old denominator we had, it was like we shouldn't leave the sun set and rise before proceeding with we shouldn't leave the small bowel obstructions unoperated. But nowadays, I think we need to compare our practice against guidelines that we have. And for the last 15 years, we have guidelines from the World Society of Emergency Surgery and the revised Bologna guidelines in 2017. So they are giving us some guidances, but there are many areas which remain unclear. So what are the things to consider when we see this X-ray? I mean, when ED colleagues call us about patients presenting in emergency department with that, as Nirav said, is a very good tool, the plain X-rays, but it's an initial triaging tool. And almost most people will think what is the cause, but what we need to focus on is the clinical presentation of the patient and also the frailty background, because we see with the age populations, many of these patients are quite frail. Something to put on the table has to do with the experience of the surgeons, because the skill mix plays a significant role on how we're going to proceed in surgical approaches. I put this slide to show you a definition of the etiology regarding small bowel obstruction. It's a very clear. It's not obviously from me. It's from a radiology actually journal, and you can see different causes. But actually, I'm gonna try to present it slightly differently. And what I was considering is that what is the journey patient when they present with small bowel obstruction in an acute hospital. And what we need to consider is the presentation of these patients most of the time has to do with abdominal pain, and many times with vomiting and distension, and most of these patients will have inability to pass flatus and stools. Clinical examination, many times, because we have all these good diagnostic tools, many people forget to do, and it needs to be paramount that we do very good clinical examinations, because we might appreciate scars, so we can orientate it towards diagnosis of additional obstruction, and also groin hernia. So we should never forget to examine the groin areas, especially in elderly people, that we might find the cause of obstruction in the groin to be encapsulated hernia. And always masses might imply a potential malignancy and also inflammatory causes that could be the cause of obstruction. So on the initial assessment also, it's very crucial to look for signs of poor perfusion. So if the patients are getting on a SERS response mode, that implies possible bowel ischemia. And also we need to do fluid resuscitation, decompression, and also be sure about the fluid balance. Regarding the diagnostic tools, I've added the ones that we use in everyday clinical practice, but the most important are the highlighted ones to my point of view. Lactate and LDH, especially when they are increasing despite the resuscitation, it's an alarm, it's a flag that most likely the patient is heading towards a ischemic segment of the bowel. And also the CT scan is a powerful tool nowadays, because it can give us not only help us identify the cause, but also we have you can have a very good planning regarding what operation we should perform, and also the level of obstruction. Regarding water-soluble studies, as Nirav mentioned, I think they are good diagnostic and predictive tools, but they are lower down the line, not initially. What will lead us to early intervention would be signs, as we said, of SERS response, so mainly tachycardia and low blood pressure, especially inotrope requirement. But what is on clinical examination is very good to remember, has to do with the colicky pain becoming a constant pain. Constant pain usually responds to ischemia of the bowel, and that is again alarming symptom from the patient that would imply ischemia. Usually, most of the times, the CT findings will show us hypoperfusion with a fluid around the hypoperfused bowel, or closed loop obstruction with ischemia, pneumatosis, and or even pneumoperitoneum in case of perforation of the bowel. So in these occasions, I think we need to accommodate the patient early to theater, because the possibility of ischemia of hypoperfusion is almost sure. Now, which are the favorable techniques in these occasions? I believe that internationally, still the laparotomy is the favorable technique in patients that they are on SERS response and they become unstable, especially with inotrope requirements. You will see, if you discuss with your anesthetist, that it's very difficult to ventilate patients when they go on SERS, especially with distended abdomen, because patients that still present straight away with peritonitic abdomen or bowel ischemia, you will not have a lot of time to decompress appropriately the bowel. Distended bowel will give you poor access, especially to areas such as pelvis. So we know that colorectal operations and also gynecology operations create most of the adhesions. So if you need to get access to the pelvis to investigate for adhesions, it will be difficult with distended bowel. And also, even for experienced laparoscopic surgeons, handling very distended bowel loops, first of all, you might lose orientation. You don't know where you're going in the abdomen. And secondary, there is a very high risk of iatrogenic perforation. So you go to release a band adhesion and you create enterotomy. So you have to convert also try to solve the problems that you created. As you can see, I mean, on the left of the picture, I don't know many people that they will try to solve this problem laparoscopically so much distended abdomen. And I think that the anesthetists will have their reservations as well. And these are two pictures from our patients. I think on the right-hand side, you can see here a closed loop obstruction, which caused, you can see the demarcation on the bowel, which caused ischemia and also congestion of the mesentery. In the middle of the picture is one of our patients that came over the weekend and had an incomplete reduction of a umbilical hernia. So actually it was a Richter's hernia. And so the patient represented on Monday with ischemic in the ring, in the neck of the hernia. And you can see here the effect on the bowel. In a sense that the patients that present with bowel ischemia, if they are not missed, the decision is not difficult to make for us because the patients need to be taken to theater. But for the patients that they don't have signs of ischemia, then we need to take into consideration what are the further steps. So the way that I'm taking forward has to do mainly with the most common causes rather than describing all the possible causes and solutions. And we know that according to literature, 50 to 60% of the cases presenting with small bowel obstruction have to do with adhesions, at least in the countries that they have advanced healthcare systems. So what do we do in these occasions? As we said, prompt decompression of the bowel and fluid resuscitation will help with spontaneous resolution. After we have decompressed the bowel, water-soluble studies with gastrografin will help appreciate the level of obstruction, and also they will help us solve the problem. The presence of the contrast in the colon after 24 hours, as Nirav said, is a good predicting factor that the obstruction is resolving, so we can remove the NG and start liquid nutrition initially. Failure of passage of the contrast to the bowel most likely will indicate that surgical intervention is needed. Now, the evidence is to be regarding the time of the intervention. So most people would say wait until 72 hours safely, but also keep in mind that the condition of the patient might change. So if you see patient deteriorating, mainly increasing of the CRP or the lactate, patients need to be taken to theater earlier. I was trying to find evidence about multiple contrast studies, as Ioannis raised before. If multiple times, giving gastrografin many times will help resolution, and actually I haven't found that, but we can discuss with Nirav as well later. What would be the surgical approach? For experienced laparoscopic surgeons and also patients that didn't have many previous operations, the guidance is like less than 2 operations will increase the possibility of a successful laparoscopic procedure, and also decompression of the bowel. But the decompression of the bowel is something which is very subjective, because we don't scan patients all the time to appreciate the dilatation of the bowel. So it's something that you appreciate on clinical examination. Here on the picture, you can see one of our patients that was operated for band adhesion. You can see it in the debekis, and she had a previous hysterectomy, and this was a band adhesion between the vaginal stump and the small bowel mesentery. The patients that will have resolution with conservative management, do they need to have operation? So if you ask most of the surgeons, nobody wants to touch a patient that doesn't have a problem. Nevertheless, the data are showing that especially young patients with small bowel obstruction should be benefited from a semi-elective operation, especially it improves it reduces the recurrence rate from 12 to 8% in a year, and from 20% to 16% in 5 years' time. And also, the semi-elective operation with the compressed bowel will increase the possibilities of a successful laparoscopic procedure. I have divided the hernias, which is another big chapter in the presence or in the presentation of small bowel obstruction, in 3 areas: the abdominal wall hernias, the internal hernias, and the incisional hernias. That mainly has to do with the decision making. And on the abdominal wall hernias, apart from clinical examination, so we should always, as I said, check the groin. The hernias that they have absence of ischemia, as we said, we can have safely groin incisions and try to repair the hernia. Nevertheless, we need for incarcerated bowel to visualize the bowel before reduction. And in cases where the bowel is spontaneously reduced, either during anesthesia or during the approach, as we try to mobilize the sac, then we can combine these procedures with the high-risk procedures of diagnostic laparoscopy. So if the bowel is reduced, you can do like a diagnostic laparoscopy and check the bowel from the peritoneal cavity, so to make sure that there is no ischemic area in the times that you are uncertain about the bowel viability. At the same time, when there is a compromise of the bowel perfusion from the umbilical port, you can put like a retractor. I don't want I mean, we can say the name of the company, like an Alexis type retractor, and you can retract the bowel from there. So you can do a very small laparotomy, and you can do small bowel resection and anastomosis instead of doing a full lower midline laparotomy. If you have to use if you want to use a mesh in the conditions where we're doing mesh hernia repair, extraperitoneal mesh repairs are favorable. But if you cannot do an extraperitoneal mesh repair technique, then open techniques are gaining more space back compared to intraperitoneal mesh repair because of the complication that intraperitoneal mesh repair has, and it creates a lot of adhesions. So these two photos are from the same patient from ours. So on the left side, you can see that the bowel that was reduced, I think this was an obese patient that came with recurrence of inguinal hernia, and during the anesthesia, actually the hernia was reduced. So we decided with my team not to go with a groin incision. We proceeded straight away diagnostic laparoscopy to investigate first the bowel. And because you can see the bowel that it is congested, but it was not ischemic. Then we proceeded with extraperitoneal repair. So we placed a mesh and closed the peritoneum, and also had a look at the bowel, which we extracted from the umbilical port side, and the bowel was viable, so we left it in the abdomen. The patient did very well. Regarding incisional hernias, it's a very large part of the bowel obstruction chapter. What I would like to highlight is that we should always be suspicious that the problem in patients with incisional hernia is not only in the sac, and especially with patients with many previous operations, you will see that you might find that the adhesions deep in the peritoneal cavity are more of a problem compared to the sac itself. And if you operate and find that there is perforation in the peritoneal cavity, you might have to extend in order to do a washout. Now, regarding repairs, I think that is very difficult to cover in a small presentation, because it has to do also with loss of domain and potential use of meshes. So we'll discuss it further later. For internal hernias, we need to take under consideration that patients might have as main symptom the pain, and they have abscess of vomiting or distension. In the CT scan, most of the times you will have a presence of closed loop of small bowel being obstructed, and these patients might have congenital adhesions, inflammatory adhesions, especially after diverticulitis or previous appendicitis, which was treated conservatively, previous blunt abdominal trauma, and also patients that have previous operations are in high risk of getting internal hernias. For bariatric patients, I will not say too much, because Ioannis has a presentation after the weather. We need to know that patients are in risk of gastric renal perforation, especially if left untreated. So for internal hernias, we can be optimistic about laparoscopic approach, especially when the patients have previous laparoscopies or if we have congenital band adhesions. Very briefly, I would like to discuss about neoplasias, the other common cause for causing small bowel obstruction. Some of them are purely related to the small bowel, and some of them to the colon, especially right colon obstructive tumors can cause small bowel obstruction, but on the CT we will have a sufficient diagnosis of that. And regarding pure like primary small bowel tumors, I think we need to consider lymphoma as the most common, but lymphomas usually they will have a dual presentation, especially when patients are under treatment with obstruction and perforation, localized perforation at the same time. Neuroendocrine tumors many times present with intussusception and adenocarcinoma of the bowel with complete obstruction, but it's extremely rare. I do not think that the water-soluble studies can help with that because actually it's not additional the cause, so they will not give us a prediction for operation, or they will not help us to resolve. So most likely in complete obstruction, we need to proceed with surgical resection of the area and to resolve the obstruction. Regarding IBD, we should try as much as possible with steroids, and for limited strictures, we can do localized resections and anastomosis. But when we have many strictures, most likely stricturoplasties are described as the favorable operations. And for other causes like foreign bodies and gallstones, I think most of them can pass easily. Gallstones usually they are stuck in the terminal ileum, so with enterotopy we can remove them. The same applies for foreign objects. We need to be conscious of foreign objects like batteries that can cause erosion at the same time, and also multiple magnets can stick together and cause necrosis of the lumen. So in these pictures on the right hand side, you can see pointing with the forceps like a persisting IBD stricture, which we repaired. Initially, we were planning to do stricturoplasty, as you can see from the orientation of the bowel, but actually we did a small bowel resection, primary anastomosis, and the patient didn't have any problem. And on the left-hand side, there's a patient that had a diverticular abscess, which actually caused small bowel obstruction, and the patient needed to get surgical treatment for that. Before finishing, I would like to highlight that the main objective should be to have a credible and sustainable solution for the patient, if it's a laparotomy or laparoscopy. If we want to proceed with laparoscopy, we need to be sure that we are comfortable, and also the skill mix that we have is good in order for us to start the operation, at least laparoscopically. The patient needs to be stable and also take under consideration the stability of the bowel. We can also use hybrid techniques. We can start with laparoscopy, and in difficulty convert to laparotomy. And comments about incisional hernias and additional obstruction. For incisional hernias, try, especially with patients that they are smoking, patients that are obese and there is a loss of domain, as we call it, meaning they are large hernias, large defects. Elective operation is favorable because the patients need to be planned better, and also to go through reduction of weight and stopping of smoking. For hostile abdomen, as we call them, that they had many previous laparotomies, and or obliterate abdomen, as you can find them elsewhere. If you go in the abdomen and find one band adhesion that is causing proximal dilatation and distal obstruction, it is very valid to not to do full adhesiolysis, but these times are going to be minimal. So in these occasions, when you have only one band adhesion obstructing, you can just divide it. If there is no clear cause, then you might have to proceed with a full adhesiolysis. So for me to conclude, I would like to raise three issues: that the clinical presentation is paramount, especially with patients that they are high risk of ischemia, so we should not lose them in the very beginning. The further delay after failure of conservative management will not bring us the favorable outcomes. Meaning for complete obstructions, I don't think if you give 5 times gastrografin after 5 days, that will make the patient, that will help you avoid operation. And also, as surgeons, we also need to know limitations. I mean, trying to push the boundaries towards laparoscopy is very good, but keep patient safety first as a priority, and don't exhaust laparoscopy as an option. And that's it for me. Thank you very much.
Thank you, Dimitrios. Very good presentation. I think it covered all the aspects of small bowel obstruction and how difficult it is to be managed by the general surgeon. We have a lot we have a lot of questions from the audience, which I will try to transfer to you. I'm
trying to stop sharing, Yanni. I'm sorry. I'm trying to stop.
Yeah. The first question was in the chat saying about a patient with chronic kidney disease previously treated for nephrectomy came with incision and hernia. How long can we delay an intervention and what workup should we go for? Of course, my question initially was if the patient came with small bowel obstruction and how urgent is this to be done? Let's say that this patient had a small bowel obstruction secondary to this incision and hernia. Dimitrios, what do you think we should do for?
I mean, if in the very beginning, we need to consider if the patient has signs that they have compromised bowel perfusion. So
I think we lost Dimitrios. I will try to answer this question. First of all, I think we need to optimize the patient. The patient with chronic kidney disease, previously treated from nephrectomy, probably he will have an acute kidney injury when he will come in with small bowel obstruction and maybe was unstable. So we need to stabilize the patient and optimize him. If the patient needs surgery because there is a small bowel obstruction, then we need to see when the patient is optimized to have this operation. If the patient is not optimized, maybe we'll have higher morbidity and mortality percentage. So we should optimize the patient. Of course, previous nephrectomy, incision and hernia is a little bit more challenging operating in the operating theaters. We need to do a lot of adhesiolysis. But again, I think the key thing is to resuscitate the patient and optimize the patient before surgery rather than rushing to go to theaters. Unless, as Dr. Patel said, that there is a sign of ischemia in the CT scan. That means it's a very urgent operation. There are some other questions like, I saw a very nice question and answer. What is the speaker's feeling about the open abdomen management for unstable patients with acute small bowel obstruction? And what about peritoneal resuscitation for segmental ischemic bowels recovery? Enrico, thank you. That's an excellent question. From my experience, I had few patients coming with possible ischemic bowel and with small bowel obstruction. And when we went inside the abdomen, we found out that the bowel is not actually ischemic, but it's like hypoperfused initially, and also with a venous congestion. So what I did in those situations, I did a laparostomy. I left the abdomen open and brought the patient to theaters after 24 hours, just to see exactly how the bowel will behave. And of course, it depends on what was the cause of ischemia. Was it small bowel obstruction? Was it like an embolus or something else? So you need to identify that. Of course, in your tools, you need to consider using sometimes what I've used was intraoperative ultrasound scan to check the perfusion of the bowel at some point. But of course, an open abdomen with a reduced intra-abdominal pressure postoperative will help the bowel to recover if there is a sign of ischemia. There is another question from Sidra. What signs and symptoms help us to decide that this patient needs to go to theater and the time of surgery? Do we have Dimitrios with us or still not? No. So the signs and symptoms, Sidra, I think Dimitrios was clear in his presentation, and I will tell the same things in my presentation. There are specific signs and symptoms like nausea, vomiting, and when you will make the decision is, I will say two things. First of all, your experience as surgeon. We all need to have the experience when the patient is going to theaters. And most of the times we see the patient from when we enter his room, if he is unwell, and what are the symptoms that they will lead us to this decision. And the time of surgery, it's, I will answer as soon as possible. Again, it depends on the age of the patient, the performance status. If the patient had previous same symptoms like previous small bowel obstruction in the past. There are many reasons that you will bring a patient to theater straight away or delay. So it is a little bit tricky. It's a very general question. I would like to have also an opinion from my colleagues. Isran?
Yes, Mr. Gerogiannis. So as you've mentioned that it is a multifactorial decision, it doesn't really depend on one factor. It starts from how the patient looks, and it helps with all the investigations. Sometimes you have time to do a bit of better investigation in terms of cross-sectional imaging. Sometimes if the patient that you think that probably is too sick for all of this, you might just rely on all the investigation that you have at hand. For example, Dr. Dimitrios said that lactate and LDH, which is quite important. It's quite a quick test, which you can run within a few minutes. And if we have some cross-sectional imaging that shows that there's any signs of ischemia or threatened bowel, then I think reasonably you have to be a bit quicker to take the patient to theatre. And on the other hand, if you think that the patient can be managed a bit more conservatively, it all depends on the circumstances on what the patient has presented with. So it will be, unfortunately with the small bowel obstruction, there can't be like a flow chart. It has to be on a patient-to-patient basis. And some patient would present stable, but within 24 hours, you see that the patient has deteriorated. So you have to change your plan and be a bit more aggressive and think about taking the patient to theatre.
Thank you, Isran. Yes, we need to be sure what is the patient status, and of course to tailor our management according to the patient. Of course, experience is very important. There is another question. What are the limits of resection of the small intestine in case of obstruction? Thank you, Alexander, for your question. The limits of resection, of course, you will see the bowel inside. If what's the length of the obstruction? Sorry, the ischemia, if there is ischemia. Of course, you cannot resect all the small bowel, so you need to check. And during the operation, you need to be very careful. Of course, you don't have to resect more bowel than you need. But this is an intraoperative finding, so you'll make the decision inside theaters. Do we have any other questions? So we can move on. Of course, we can reply the question a little bit later on. I will move with my presentation now. I will try to share my screen. The presentation I will do is for small bowel obstruction, the bariatric patient. All of those presentations that we've had before was for patients in general and with various conditions, but bariatric surgery is a different era, especially in modern medicine. When we have a percentage of bariatric patients coming to the hospital on a daily basis. So I don't have any conflict of interest. Consent was obtained from every patient who participated in this presentation and study. So small bowel obstruction, I will not say a lot of things because Dimitrios said and Dr. Patel said about this. Very common condition, sometimes can be lethal. The cause can be adhesions, hair-related, foreign bodies, tumors, strictures, inflammatory or other conditions. The small bowel obstruction, the symptomatology can be abdominal pain, nausea and vomiting, distension, difficulty in breathing, dehydration, constipation, let's say this is what the patient is feeling, or loss of appetite. The clinical picture, the patient will be unwell. He or she will be tachypnoic, tachycardic, hypotensive, dry, the urine output will be low. There will be a generalized or localized abdominal tenderness, depending where there's a pathology, tympanic abdomen on percussion, not passing flatulence or not opening bowels. This is what's happening in most of the patients. This is how a patient with a small bowel obstruction looks when he or she comes to the hospital and presents to the hospital. But is this a small bowel obstruction? This is a patient with overweight, obese, with previous bariatric surgery. Are we sure from by looking at this patient that this patient has a small bowel obstruction? I'm not sure. The reason is that obesity is related with a lot of diseases. Patient with extra kilograms and actually with a BMI above 30 can have a metabolic syndrome, which a metabolic syndrome can be some disease like arthritis, respiratory disease, sleep apnea, gastroesophageal reflux with fatty liver disease, esophagus, uterus, or pancreas and kidney cancers, high triglycerides, insulin, diabetes, low HDL, joint problems, high blood pressure, heart disease, almost everything. So we need to be careful about this patient. They have a lot of pathologies. And when we say bariatric patient, what do we mean? Bariatrics is a field of medicine that deals with weight loss, weight control, and obesity treatment. The origin, I'm sure most of you know, it comes from the Greek word varos, which means weight, heavy weight, or load. Herodotus, Aeschylus, and Sophocles introduced this word. And iatre, that means iatrikos, Greek iatrikos, iatros, that means physician and treatment, and the ik that is pertaining to. In modern medicine, we say bariatrics. Bariatrics is a broad term. However, most of us, we use the term metabolic surgery for that because we deal with patients with metabolic problems. So the bariatric patient is could be an obese of a BMI 30 and above, plus minus multiple comorbidities, diabetes, sleep apnea, cardiovascular, other comorbidities, maybe had previous abdominal operation, maybe had previous bariatric surgery. This is one part of the patient we see. The second part of the patient is a bariatric patient, a bariatric patient that had a previous bariatric surgery, and now the BMI is normal, has existing comorbidities that some of them may be disappeared after bariatric surgery, and plus minus previous abdominal operations. So we have two types of patients when we say bariatric patient. All of them, they have some difficulties on management. So the small bowel in bariatric patient often missed, it can mimic other pathologies, and of course can be lethal. The cause will be the same, but in bariatric patients, adhesions are maybe more likely. Hernia related, yes. Foreign bodies, maybe, and you will see, it depends on the operation that someone had from bariatric surgery. Tumors and strictures, yes. So from the symptomatology, a bariatric patient, most of the times will not have abdominal pain. I'm saying to my trainees all the time that when the bariatric patient will appear with abdominal pain, maybe the pathology is quite severe and maybe it's too late. Vomiting and nausea, not all the time. The bariatric patient will have distension, difficulty in breathing, dehydration. Sometimes difficulty in breathing is a question mark because maybe he had difficulty breathing even in his normal life because he has a sleep apnea or he has some COPD or he's using a BiPAP. So difficulty in breathing is not a symptom that you need to take in consideration all the time. Loss of appetite, I'm not quite sure. I had patients that they came with small bowel obstruction and her appetite was really good. Regarding the clinical picture, patient will be hypotensive. I'm not 100% sure. Most of those patients, they have high blood pressure and extremely high. Most of them they don't have the proper management for that. Dry, not most of the times. Generalized or localized abdominal tenderness on examination, abdomen is non-tender most of the times. Tympanic abdominal percussion, I will give you congratulations if you you find a tympanic abdomen on a bariatric patient or a patient with a BMI of 40. Unwell, most of the patients, they don't look unwell. Actually, I remember I had a patient very unwell with biliary peritonitis in the ward, reading his newspaper and saying, I'm quite well, but he had biliary peritonitis. Tachypnoic, again, I'm not sure about this. So difficult, it's very difficult, the decision making. What we can do about this? First of all, summarizing why the decision making is difficult, because clinical picture is not clear. There is a different anatomy of the gastrointestinal tract. Dr. Patel said earlier that there are some variations. I will show you some variations regarding bariatric patients. Different metabolic response, and most of the patients can have, they can be immunocompromised or have significant comorbidities. So the bariatric operations are the sleeve gastrectomy. You all know Rowan-White gastric bypass, one anastomosis gastric bypass or mini gastric bypass, duodenal switch, gastric band, gastric balloon, endoscopic sleeve gastroplasty. Let's take one by one. Sleeve gastrectomy. We all know what a sleeve gastrectomy is. A part of the stomach is removed, so the patient has also a good result by having less volume, but also metabolic result. However, there is a case report in literature that an unusual cause of bowel obstruction was found after laparoscopic sleeve gastrectomy. And actually, you can see the pictures here. The CT scan showed a dilated stomach with like collapsed small bowel loops close to the stomach. What was the case? The staph line from the sleeve gastrectomy caused a band adhesion, and a small bowel was in the left upper quadrant, causing obstruction, closed loop obstruction. So it can really happen, and we need to be aware when we have a patient with sleeve gastrectomy coming back. Complicated. We have a lot of two anastomoses. We have a lot of defects. You can see the mesocolic defects if someone will do a retrocolic anastomosis, Peterson's defect, and mesenteric defect close to the Gerogiannis anastomosis. So 3 defects, 3 areas that someone can have small bowel obstruction. How we can find this? It can be very difficult to diagnose. I think we need, first of all, a very good radiologist like Dr. Patel to find out. Most common symptoms: abdominal pain, nausea, and vomiting. Abdominal pain, though, cannot be present sometimes, and this will give a problem to the patient and the clinician. Vomiting. Now, I want you to see this. This is the anatomy of the Rowan-White gastric bypass. So if the obstruction will be to the root lymph or close to the problem will be close to the stomach pouch, then patient will have retching or small amounts of clear emesis, but not a lot of vomiting. What about if the obstruction will be in the biliopancreatic lymph? Then there will not be any vomiting. If the patient had this obstruction below the site of Gerogiannostomy, then the patient will have bilious vomiting. So as you can see, the type of vomiting is very important to the patient and the clinician when we'll try to find out where the obstruction is in a Rowan-White gastric bypass patient. So furthermore, lower sensitivity of radiological studies in post-Rowan-White gastric patients. This is like a study from 2007 in Archives of Surgery. Also, abdominal X-ray sensitivity from small bowel obstruction was 33.3% post-Rowan-White gastric bypass versus 70 or 80% general population. Also, the study showed the CT scan abdomen pelvis sensitivity for small bowel obstruction post-Rowan-White gastric bypass was 50% versus 80 or 90% in the general population. So you can understand CT scans and imaging in general cannot help in a clinical diagnosis. From the metabolic aspect, it's quite interesting to see what was published in Surgical Obesity Related Disease in 2015. You can see high amylase levels in patients with small bowel obstruction post-Roux-en-Y gastric bypass. Of course, it depends where the obstruction is. If the obstruction is in the pileo-pancreatic limb, or it is lower than that, or it is higher than that, like higher on the jejunal anastomosis, high lipase levels, elevated pancreatic enzymes, which show that there is a high sensitivity for detecting acute small bowel obstruction, 64%, and especially if the obstruction is in the pileo-pancreatic limb, it's 94%. Deranged LFTs. The decision making. It's quite challenging because if you have a normal CT scan, this doesn't mean that you don't have a small bowel obstruction post-Roux-en-Y gastric bypass. When abdominal X-ray did not explain the symptoms, we should request a CT scan immediately. Of course, it is very, very important, and Dr. Patel, I'm sure you will agree with me, you need to make a request mentioning exactly the clinical details and the history of the patient. Because if you ask for a CT scan without mentioning the patient had a Roux-en-Y gastric bypass, then it will be very difficult for the radiologist to make a diagnosis and write a proper report. It is very important for the radiologist to know exactly the clinical details, what kind of operation the patient had. Review scans with an experienced radiologist, of course. Negative imaging, but clinical suspicion and experience can lead with a diagnostic laparoscopy without a delay. One of my mentors many years ago, a bariatric surgeon, told me when I was a fellow that if a patient with a Roux-en-Y gastric bypass comes with abdominal pain, a lot of abdominal pain, which cannot be explained from the clinical examination and the history, we need to do a diagnostic laparoscopy straight away without even asking for a CT scan, because most of the time, patient has an internal hernia. Small bowel obstruction in post-Roux-en-Y gastric bypass patient can present from day one until 7 years post-Roux-en-Y gastric bypass in literature. Of course, I've seen patients coming after 12 years or 14 years or more. The early small bowel obstruction can be because of technical problems during surgery or the anastomosis. Late can be additional internal herniation. Most of it is a common channel obstruction. Operating tips. Diagnostic laparoscopy versus laparotomy. Of course, this is a decision that someone can make when we see the patient and see the risks and benefits. However, if the patient is still obese, diagnostic laparoscopy has very good results. We need to know about the operation notes. What kind of operation the patient had? Did they close the defects? Was it another type of complication? Did they do any other type of variation of Roux-en-Y gastric bypass, especially if this operation was done by non-bariatric surgeon? Ideally, the emergency surgeon who will do this operation should be familiar with bariatric surgery. You need to know at least how Roux-en-Y gastric bypass is performed technically, so you will see and search and identify the anatomy intraoperatively. Otherwise, you will be lost. One of the tips is to start exploring the small bowel distal to proximal. You need to start from the allocecal valve and running up. So you will see, first of all, you will see the jejunal anastomosis, and then you will go up and you see the gastrojejunal. And of course, you can identify the pattern sense defect and the mesenteric defect to find out if there is a problem in internal hernia. Very careful of grasping the bowel. We have a lot of iatrogenic perforation when you grasp the bowel. Close the mesenteric defects if possible. And we need to be careful also postoperatively with nutrition support, because Roux-en-Y gastric bypass patient can have nutritional problems before, or not being well managed or follow up by the bariatric surgeon. One anastomosis gastric bypass, you have still the Peterson space, but it's a little bit more wide, longer pouch, That means there is a high risk of having an internal herniation, incarceration, strangulation, but it's a little bit less than a Roux-en-Y gastric bypass. And this is what was shown in literature. Gastric band. Gastric band can cause, of course, gastric outlet obstruction. We know that patients died from this situation. However, there is also a case report which I found very interesting in literature, bowel obstruction and cecal volvulus as a complication of a laparoscopic gastric band. You see this X-ray that the gastric band is in the middle abdomen, and sorry, the gastric band is higher here. This is the port, and you see loops of small bowel gathered in left upper quadrant causing obstruction. Duodenal switch is a little bit more less common operation, but again, it's a little bit challenging because obstruction of the alimentary lip can cause nausea, vomiting, and abdominal pain. However, you need to know which part of the bowel is obstructed, so the patient will present with different symptoms. Also in literature, there is a publication about internal hernia after revisional laparoscopic loop duodenal switch surgery. Gastric balloon, of course, gastric outlet obstruction or discomfort, or also a mechanical intestinal obstruction when this balloon was deflated and went to the small bowel and caused small bowel obstruction. So we need to know what kind of procedure was done, what kind of balloon was inserted, the branch sometimes, because they have different branches and different techniques. So you need to know everything about the previous operation before assessing the patient. So summarizing, take-home messages are chronic and intermittent abdominal pain, left upper quadrant, and nausea can be a presentation of internal hernia after Roux-en-Y gastric bypass or one anastomosis gastric bypass. Many patients are coming with chronic left upper quadrant pain and nausea, and at some point they go to the hospital in an emergency situation having more pain than usual and more nausea than usual. This is an alarming sign that there is an internal hernia there. Obese patient, very challenging patient regarding clinical examination. Clinical examination is of low value for many reasons. I call the obese patient a silent bomb that can explode at any time, even sitting nicely in his chair during close to his bed in the ward. We need to have a high suspicion of small bowel obstruction in bariatric patients. Deranged LFTs do not always mean liver pathology in bariatric patients. Can mean a small bowel obstruction. Deranged amylase or lipase do not always mean pancreatitis to obese patient. It can mean small bowel obstruction equally. Obtain info of the type of the previous bariatric operation is very important to know what kind of operation patient had before, not just writing the note, patient had bariatric operation 3 years ago. We need to mention exactly what operation had. And perform CT scan as early as possible. Consider diagnostic laparoscopy, sometimes without even a CT scan. Use those intraoperative tips and tricks we discussed. And of course, proper postoperative care, including nutrition support to patients with previous bariatric surgery. Thank you very much.
Thank you very much, Ioannis, for that great run through of everything you ever wanted to know about small bowel obstruction in bariatric patients, but were afraid to ask. Actually, there is a question that somebody has asked, which is, would you suggest that small bowel obstruction in bariatric patients should always be managed by people who are experienced in bariatric surgery?
Well, I think I've mentioned that during my presentation. Of course, if you have experience in bariatric surgery, it will be more easy for you to identify the problem. You know the anatomy, you know how the operation is done, so you can, of course, you will have experience by patients having complications postoperatively, but also you will be very familiar with the anatomy, so you will sort out the problem of the patients quite quickly. This doesn't mean that a surgeon without a bariatric surgical experience cannot save a patient with a small bowel obstruction. All of us, we can do that. However, being familiar with the operation will save you time intraoperatively, will cause you less discomfort yourself during the operation, because sometimes Roux-en-Y gastric bypass patients are a really nightmare exploring them with a diagnostic laparoscopy. You don't know where you are, you don't know where the small bowel is going, so it's a nightmare. But of course, as I said, it's better for you to have a bariatric experience, but not essential. It's not essential.
Okay, and another question for you. You've told us in your talk how difficult it is to diagnose the problems with bariatric patients. So we've got a question that follows on from that, which is, are there any red flag symptoms that are specific to this sort of problem that we should be looking out for?
I think the red flag symptom in a bariatric patient is pain, a lot of pain. If a bariatric patient has a lot of pain, and from the history you cannot understand what's going on, why this patient has a pain, then you need to have red flags coming from everywhere. And of course, if you have a bariatric patient that looks unwell, or on clinical examination you just press the abdomen and it's jumping up with because of pain, that means there's something serious going on.
Dimitrios, you want to comment?
I just want to add to what Ioannis is saying about this type of patients. So a high clinical suspicion is something that we should always have in this type of patients, because the symptoms might be silent, and the loss of the disturbance in the continuity of the bowel actually is affecting the classical finding of vomiting. So we need to have high suspicion when we see patients that had previous bariatric operation that internal hernias and small bowel obstruction can be very silent. So tachycardia and increasing lactate in a patient with pain, which is becoming more and more difficult, should raise high suspicion. And even if a scan is not giving a clear answer, then, as Ioannis has highlighted, diagnostic laparoscopy should be the step forward, and ideally by somebody that has advanced laparoscopic bariatric experience. But if the patient is unwell, then it's better to solve the problem of the patient than rather delaying it and lead to like a catastrophe.
Thank you, Dimitrios. I think we should move on, because I can see Isran is ready to go. Last but not the least, Mr. Shah is a senior clinical fellow in general emergency surgery at Kingston Hospital, NHS Foundation Trust. He's one of the most experienced clinical fellows in our trust in surgery. I'm very happy to have him on board. And I'm sure his presentation, Paul, and the case that you will present are very, very interesting. I'm looking forward to it. Isran.
Thank you so much, Mr. Gerogiannis. So to start with, let me just share my screen. So we've had talk about almost all kinds of scenarios for small bowel obstruction. So let's see that.
Share your screen, because we cannot see your screen.
Let me see if I can try again. Any luck?
We can see it now. We can see it now. Yes. Thanks.
Oh, it's okay. So we've had to talk about the small bowel obstruction, and let's see that what these patients present like in real life or in practice. So to start with, these are very common scenarios, because our target audience was from budding surgeons to consultants, practicing surgeons, and it's not an exam, it's an interactive session. So I think we should take part in it. Let's start with the first case. So we had a 64-year-old gentleman that presented to our emergency department with 24 hours history of colicky, abdominal pain, and bilious vomiting. He hadn't opened his bowels for about 24 hours, wasn't passing any wind. He had no red flag symptoms regarding his bowels. had a past medical history of a rectal cancer that was diagnosed in 2006, had an open anterior resection with uncovering ileostomy, followed by some chemotherapy, and then the stoma was reversed in 2007. 5 years follow-up, he was disease-free, and he was on amlodipine for some hypertension. On examination, observation-wise, the patient was quite comfortable. There was no other abnormalities on his general physical examination. Abdominal examination revealed a midline laparotomy scar and a scar in the right iliac fossa, no obvious abdominal distension, no groin hernias. The abdomen was soft, non-tender, non-peritonitic. PR examination was unremarkable. His investigation showed a white cell count of 14. Rest of his full blood count was normal. Urea electrolytes were normal. Clotting was okay. LFTs were normal. His blood gas, initial blood gas on presentation showed a lactate of 2.4, although it came down to 0.8 with resuscitation. And on the blood gases, his pH base axis was preserved, and he was further resuscitated in ED. An initial abdominal radiograph was obtained, and that's what we can see on the screen. And if everyone has had a brief look of it, let's move on to our first poll. So we've got a bit of a background of the patient, and we've seen the initial radiograph, and let's see what we need to do. Shall we admit this patient and give some laxatives, because we think it's just a bit of constipation? Or shall we discharge this patient home and get some laxatives, give some laxatives and see what happens? Or do we have enough evidence in terms of his history and the abdominal X-ray that we should proceed to some cross-section imaging in terms of a CT abdomen pelvis with contrast? All right, so I think that we should have an answer. And as you can see, that most of the people 100%. Have 100%. So that means that we're winning at the moment. Let's continue further. So we had the CT scan, and on the CT scan, you can see that there's some dilated loops of small bowel, as Dr. Patel initially talked about, that there's a transition point with most of the regional small bowel obstruction. If you look closely, there is a bit of the collapsed loop of bowel right next to the distended loop. It looks a bit better on the coronal views. You can see that the small bowel is dilated, and you've got some collapsed loop of small bowel down in the pelvis. An interesting thing on this CT scan is that if you look at the upper abdominal imaging, there is something that should never happen if you're suspecting a small bowel obstruction. So if you see the stomach, you can see that it is distended, and it's a patient that was having suspicion of small bowel obstruction and was sent to the CT scanner without an NG tube, which should not happen in real life. It prevents an NG tube before a CT scan, prevents aspiration during the scan, and also it gives you a good idea about the location of the NG tube when you scan the patient afterwards. Moving on, we admitted the patient, inserted a wide bore NG tube, and kept it on free drainage and 24 hours aspiration. The patient was sent onto the ward. 24 hours into the admission, there were no further abdominal pains, but unfortunately the bowels had still not opened and the patient wasn't passing any wind. The NG aspirates in the last 24 hours were about 650 mils. Serial repeat abdominal examinations showed that the abdomen was completely soft, non-tender. Repeat bloods and repeat blood gases were all completely fine, with normal renal function, normal lactates, and the rest of the blood gases. So we've gone one step further. We've got another poll. So we've got this gentleman who's quite stable, but hasn't opened his bowel for about 24 hours. What shall we do? As said that previously, it is thought that you can sit on them for about 72 hours nowadays. So do we have more time? Do we observe them for another 24 hours? Or have we had enough? And let's take him to theatre and do a laparotomy and do some adhesiolysis. Or do we trust our laparoscopic skills? Let's try some laparoscopic adhesiolysis for this gentleman. Or let's give him some gastrografin and see how it goes. All right, okay, so we've got multiple answers here, and I think that the right thing when someone who's quite stable has got a transition point and repeat examinations have been stable, and we still have some time on board to play with. So I think the best thing would be to try to give him a gastrografin challenge and see how it goes. So this patient was given some gastrografin. And as you can see, this is a 9 hours post-gastrografin image. And you could see that the gastrografin is, you can trace the gastrografin all the way back down to the rectum. So the patient had opened the bowels successfully the next day. Normally, patients who are obstructed, and if you give them gastrografin, because we know that gastrografin is quite potent laxative as well, they do open the bowels quite a lot and flood the house. So you have to be a bit careful that to make sure that the patients are not dehydrated because of the loss of fluids from the GI tract. We started building up the patient's diet. We figured the NG tube, started on clear fluids and went into free fluids and slowly progressing to a low residue diet. The patient was discharged home without any complications, and we haven't seen the patient since. So that's the first case, and let's move on to the next one. So the next one was a 56-year-old female that presented to our emergency department with acute onset of central colicky abdominal pain, which was associated with projectile bilious vomiting. Now, the important thing in the history here is that the pain has started about 4 hours ago, but the patient hadn't opened her bowels in about 24 hours and wasn't passing any wind, was feeling a bit nauseous before she started vomiting. No alarming bowel symptoms prior to the presentation. She's had a past medical history of an ovarian mass that was diagnosed in 2015. There was some suspicious of malignancy. She underwent a total abdominal hysterectomy with bilateral oophorectomy. The histopathology showed that it was a benign dermoid cyst. She also had a previous cesarean section. She was on some hormone replacement therapy, otherwise was fit and healthy, was a solicitor. And when reviewed in our emergency department, the patient was vitally stable, but from the end of the bed, she was in quite a lot of distress and discomfort because of the abdominal pain. An NG tube had been placed, and that had drained about 500 mils of bilious fluid. And the other thing is that because this patient was persistently vomiting, so probably she's vomited, she's decompressed her stomach a bit more than 500 mils. Was given adequate pain relief in A&E, but unfortunately we were not able to get on top of her pain. On examination, general physical examination reveals a patient that was in obvious pain with some slightly dehydrated mucous membranes. No other positive findings on the general examination. Abdominal examination reveals an abdomen that was distended with a sinential incision, soft without any signs of peritonism, but there was some generalized abdominal tenderness. No external hernias, and PR examination was unremarkable. Routine investigations showed urea and electrolytes, LFTs were all normal, white cell count was 16, CRP was 35. On presentation, her lactate was 1.5, pH was normal, bicarb, base axis were all normal. Clotting was in normal range. An abdominal X-ray showed that she's got some dilated small bowel. Chest X-ray didn't show any free air under the diaphragm. So this time we've got a bit of a different scenario. We've got a patient who's got some abdominal pain and has had some vomiting. Blood-wise, there's nothing too exciting on the bloods. So what should we do from here? Shall we put the NG tube, leave the NG tube in and observe for another 24 hours to see how it goes? Or shall we give her some further painkillers because we need to control her pain, and then review in 4 hours time to see if it's adequate pain relief that can get on top of the pain? Or shall we proceed to a CT scan to see what's going on? Or do we have enough evidence at this point to take her to theatre? All right. Okay. So, as most of the participants said that we can do a CT scan, although it can be argued that this patient could be taken to theta, but I think at this point, the evidence of taking her to theta was a little bit low. So we did a CT scan for this lady. And the CT scan showed a small bowel obstruction with no obvious cause, but adhesions were a possibility. We've got some images here, and if you look at it, you could see that there's some dilated small bowel loops, and there is a loop of a collapsed small bowel that you can see here. And if you look with the eye of faith, unfortunately, it's not a dynamic image, but there was some mesenteric swirling or the whirlpool sign in the mesentery of the small bowel. And as Dr. Patel said, that the whirlpool sign has to be interpreted in the right clinical context. So what should we think that what should be the management for this patient? Should we start a PCO on this patient and give some aggressive fluids, put an NG tube and free drainage and aspiration and observe? Or should we admit this patient, decompress the bowel for 24 hours, and then give a gastrografin once the bowel is nicely decompressed? Or now we have enough evidence that the patient has got to go to theta? Or shall we give her some gastrografin right now and then do an X-ray in 4 hours time to see if the contrast is still in the small bowel, and then take her to theta from there? All right, so I think that the most important thing in this scenario is that where we've got a patient that we're not able to control the pain. We've got a CT scan that shows that she's got small bowel obstruction. And despite our efforts, we can't really get on top of the pain. And as it was mentioned earlier in the talk, that pain is one of the warning signs that if someone with small bowel obstruction has got abdominal pain, you could have something alarming going on. So the decision was made to take the patient to theta, given the high clinical and radiological suspicion. Well, actually, the radiological suspicion was not too high. It was just the pain in this patient's context that was alarming. So we took this patient to theta. Intraoperative findings was a mental band that was causing a small bowel obstruction in the mesenteric twist. There was some dilated small bowel that looked congested, but you could feel the pulses, and also there was no obvious signs of any venous ischemia. I'm sure that most of the surgeons have come across an image like this, where you can see on the left of your screen, there's some very normal looking dilated bowel. On the right of the screen, you can see that there is an angry looking bowel, and you can see in a mental band that was causing the internal hernia. Now, if we keep this image in our mind, what do we think that we should do next? Should we resect this bowel and do a primary anastomosis, or should we resect this bowel and bring out a double-barrel stoma, or shall we pack the bowel with some warm saline soaked gauzes and examine in about 15 to 30 minutes and see how it goes? Or shall we do a laparostomy, send her to ITU, and relook in 24 hours? So I think that most of us are out to the bowel. So what we did is that we released the band and we packed the bowel with some warm saline soaked gauzes and returned the bowel back into the abdomen. While we did that, we looked for other causes to make sure that there was no other pathology. We ran the small bowel, looked at the peritoneum and all the other stuff that you need to do in laparotomy, and there was no other pathology found. The congested bowel was re-examined and was found to be viable. The abdomen was closed and the patient was shifted to ITU. And you can see that after about 20-25 minutes of some saline gauzes, the bowel had nicely pinked up, and the bowel was peristaltic and it was going through. There were no constriction rings that looked abnormal or looked like threatening on the bowel. And with the transition point, which was in the distal bowel, you could see that the fluid was nicely transitioning into the distal bowel. So post-op recovery was unremarkable. The patient was discharged home on the 5th post-operative day. On follow-up appointment, the patient did not have any problems, and the patient had returned back to work. So I think the point to take home on this slide was that when it comes to small bowel obstruction, the time is of the essence, and then a few more hours in a case like this, you end up losing bowel. In this patient's case, is almost more than 1 meter of bowel, which is still quite significant. So when there is doubt, it is always better to have a look at the bowel to see what's going on there. Someone forwarded me this image over Christmas where someone was asking for a really good bowel moment. But I think that's the surgeon which is asking center for its patients to have a good bowel moment. And I think that's all for today. Thank you so much for your participation. And I'll hand it back to Mr. Gerogiannis.
Thank you very much, Isran. I think those presentations are real life scenarios. We see them every day. They triggered me to raise some questions here, and those questions are going also to you, Jonathan, and Dimitrios and Nirav. In my practice, when I see a patient that is definitely obstructed clinically, and we ask for a CT scan, and the CT scan comes back with the clear sign of small bowel obstruction because of a band adhesion in the right iliac fossa, for example, with a patient with a previous open McBurney's. I don't use gastrografin. I go straight to theaters to operate and release this adhesion. Of course, this was demonstrated also with some answers in the polls during Isran's presentation. Some of us will go straight to theaters rather than losing time with gastrografin. I'm saying that from another point of view. We know that the cause is adhesional. We know that there's a band which is shown clearly in the CT scan. If you give gastrografin, we all operate patient post-gastrografin. The bowel is very friable. The bowel is very edematous. You want to release the bowel, and sometimes you can open the bowel while you manipulate it because it's so edematous secondary to gastrografin. And sometimes I feel really when I operate patients that they left 2 or 3 days post-obstruction with gastrografin given, I feel like they look like inflammatory bowel disease patients. The bowel is so friable, it's very easy to open. What is your opinion about this?
I'm not sure what your question was there, Ioannis. That was quite a long lead into it. But if you have patients who, we rely very heavily on working closely with our radiologists. And if you have a very obvious obstruction from a band adhesion, then you'd go and operate anyway. If you have something which may be a partial obstruction, then that might be an indication for gastrografin. But it depends on really the extent of obstruction. And this is something that Nirav showed quite nicely in his presentation.
Jonathan, thank you. I think my question was, it was going most to the someone experienced during surgeons or junior trainees, that they think that the pathway is clear. Someone is coming with small bowel obstruction, imaging, gastrografin, if not setting down operation. This is not always the pathway. And I'm saying that sometimes if someone will, we all have colleagues that they follow this pathway like by the book. But I've seen patients that they came to my on call with a 2 days post-presentation with gastrografin given. And the operation was quite challenging because of the gastrografin itself. So that's what I'm trying to say, that if in your experience you avoid gastrografin when you are a little bit sure that what the problem is and you can like solve it surgically, or you give gastrografin anyway. This is mainly my question. Dimitrios.
Yanni, I would individualize it according to the patient, especially for younger patients. Most likely, bad adhesions will be a recurrent problem. So most of the times, I would opt in for decompression and then possibly for diagnostic laparoscopy instead of giving more time to gastrografin. For more elderly patients, especially the ones that they have increased frailty score, I would give more chance to the gastrografin, because I would hope that the recurrence that they will have is going to be after some years. So we don't know if they will reattend or not. So I individualize it according to the frailty and the age, unfortunately.
Thank you, Dimitrios. Have you seen intraoperatively those findings that I said to you, like a bowel that is quite edematous, especially just before the area of the adhesion, because gastrografin was trying to work in this area, and because of the osmotic defect, the actually bowel was quite dilated and edematous and very difficult to, very easy to open.
I don't know where the effect of the gastrografin and where the third space fluid from the obstruction comes to that. So yes, especially when we have delayed presentation, if you go to operate after the second, third day, the bowel will be more edematous and it will be very difficult to handle it. Though to my experience, I don't know how much to blame gastrografin or how much the delay.
Thanks.
I'm going to take the opportunity to echo what one of the participants has said this evening, has asked us to raise, which is that there are some very clear indications for surgery. There are things on CT scans which are very obviously an indication for surgery. There are things you find on patients which are very obviously an indication for surgery as well. And at the end of the day, whether you use gastrografin, whether you use CT scan, or whether you use a plain abdominal radiograph, those are all investigations, and they don't actually, except perhaps with the exception of the gastrografin when it's therapeutic, they don't usually make the patient better.
Thank you, Jonathan. I think the take-home messages from all the speakers is to see the patient holistically, to see the patient from top to bottom, examine the patient, be a clinician first, and then, of course, communication skills with and work as a team with the radiologists is important. I want to highlight something, and I want to praise Isran for that. When he has a patient that is a little bit challenging, even though the patient had a CT scan and reported by another radiologist, he's going and see the on-duty radiologist, discuss again the CT scan, because 4 eyes are better than 2. And we've realized, and I want Nirav's opinion about this, we've realized that sometimes the reports are a little bit different when they come from a different radiologist with a different experience, and sometimes they can change completely the management of the patient and, of course, the outcome.
Yeah, that's absolutely correct. So I work in a department with 40 consultants and 40 residents in total, and you've got a wide variety of experience and interests. And you know, we are a very busy centre, and overnight you might have a very senior resident giving an opinion, but it may not be absolutely correct, or it may miss some of the pertinent findings that we've discussed. They may give an overall view to give a management for those few hours, but actually come the morning or after maybe 12 hours, something's not progressing right with the patient. And it's very important to go look at imaging again. I mean, I would always encourage surgeons to look at the imaging themselves to learn from it, but actually going and sitting down with the radiologist, the one that might be, in this case, we're talking about abdominal surgery, having a look at with a GI specialist and sitting down and having that. I often get surgical colleagues come down with a coffee to sit down a bunch of cases from their take, but actually it's much more rewarding because you'll see actions being made as a result of that re-review. So a decision saying, actually, we need to take to surgery, list them for surgery this afternoon, we need to take them, that sort of thing. Just because, and sometimes we're in a center, I've seen some of the messaging here around, we're in a center where we often get imaging very early just because of the nature of where we are. But that decision and that review is very quick. Everything's happening rapidly. You don't have all the information yet, and you're trying to gather as much as you can. And sometimes all it takes is someone to step back, take a wider view of the picture, what's happening, going back with all the full information that has been obtained at this point and re-reviewing again.
Great points. Thank you very much. That's excellent. Thank you. Do we have any questions from the panel or from the participants? No.
So I think this is probably a very good place to draw this excellent webinar to a close. I'd like to take the opportunity to thank our panelists, Nirav Patel, Dimitrios Tsironis, Isran Shah, and Ioannis Gerogiannis, and also to thank our webinar team, Diego Mariani, Alan Bilislavo, Hayata Kuriara, and Mauro Zago. I hope you've enjoyed this evening's webinar and that you will join us next time when we'll be looking at polytrauma in our next webinar. Thank you very much for being with us this evening, and look forward to seeing you again soon.